Welcome all for the today's class. So today we continue with our pathology module, and today's topic is neoplasia, metastasis and cancer progression. So what exactly the neoplasia is? Neoplasia by definition, neoplasia is an abnormal, excessive, purposeless, unwanted, unrestricted or uncoordinated growth of the tissue that persists even after removal of the initiating the stimulus. Okay, so even if you remove the stimulus, then also the growth of the tissue continues. So the word neoplasia, how it is derived, neo means new and plasia is formation. Okay, so this definition you should remember, because sometimes on these particular features they can form a SBA. What are the key features of the neoplasia? It is the loss of responsiveness to normal growth control. Then growth is autonomous. Neoplastic cells are usually monoclonal, arise from one transformed cells. Non-neoplastic proliferation is there. Generally, inflammation are usually polyclonal. So non-neoplastic proliferation are usually polyclonal in nature. Okay, so this is what is the definition which you should remember. An abnormal, excessive, purposeless, unwanted, unrestricted, uncoordinated growth of the tissue that persists even after removal of the initiating the stimulus. And these are the key features what we have seen. Now, what exactly the biological behavior of neoplasm is and what are the general characteristics? So, neoplastic tissues behave like parasites. They will depend on the host for nutrients. Tumor grows while patient becomes wasted. Okay, so the patient will develop wasting, but the tumor will grow. Okay, what are the important features? There is an autonomous growth, excessive proliferation, and reduced response to regulatory signals. Then what are the types of neoplasms? Neoplasms, it may be benign neoplasm or it may be malignant tumor or cancer, what we call it as. So there are specific differences between the two. Benign tumors are slow growing, generally localized, well differentiated, non-invasive, no metastasis, usually when encapsulated, recurrence is rare, and generally they are not fertile. Okay, so these are the characteristics of the benign features, benign tumors. While the malignant tumors are, they have the rapid growth, they are invasive, poorly differentiated or anaplastic. They have the characteristic of invasion. They are metastatic, generally not encapsulated. Recurrence after the surgery is known, and they are potentially fertile. Okay, so special characteristics of the malignant tumors. So for malignant tumors, there are very specific features. One is a loss of contact inhibition. Okay, so they will continue to grow despite the contact with the adjacent cells. Okay, so even if they are separated from the adjacent cell, they will continue to grow. Then dyscohesiveness. Tumor cells lose adhesion to one another. Okay, so this is also one of the characteristics, that is dyscohesiveness. Tumor cells lose adhesion to one another. Then next is an invasion. The tumor cells bind to laminin and fibronectin, produce proteases and collagenases, and destroy the surrounding tissues. So the characteristic of invasion is because of these particular features. Because of the binding to laminin and fibronectin, they produce proteases and collagenase, and that is how they destroy the surrounding tissue, and that helps in invasion. Metastasis, spread to the distant organ, and cellular immortality. So there is an unlimited proliferative capacity these cells have. Okay, now what are the terminologies which are used generally when we talk about the neoplasia? What is parenchymal cells? What is mesenchymal cells? That we should know. So parenchymal cells are the functional cells of the organ. Okay, they may be glandular cells, hepatocytes, surface epithelium. These are called as parenchymal cells. The mesenchymal cells, these are the supporting stromal tissues. Okay, that is, these cells belong to these stromal tissues, which may be fibrous tissue, muscle, bone, cartilage, blood vessels, and we can have the neoplasia from the parenchymal cells, as well as it may develop from the mesenchymal cells also, and accordingly their terminology will change. Okay, so what is the nomenclature of the tumors? So when we deal with benign tumors, generally there is a, in general rule is that we put the suffix as a oma. Okay, so if it is a fibrous tissue, we will label this as a fibroma. Fat, if we will call it as a lipoma. Cartilage, chondroma. Bone, osteoma. Glandular epithelium, adenoma. Surface epithelium, papilloma. Okay, so generally oma denotes the benign tumor. Okay, but this is in general rule. There are certain exceptions that also we will see. Then malignant tumor. Malignant tumors are the cancers of the carcinoma. Malignant tumors arising from the epithelium, such as glandular epithelium, what we call it is adenocarcinoma. Then if it is arising from squamous epithelium, we label this as a squamous cell carcinoma. So when we deal with malignant tumors, we use the terminology as a carcinoma, while for benign tumors, generally suffix oma is used. Then sarcoma, it is the malignant tumor arising from mesenchymal or connective tissues. Okay. So even if this is oma, this is a malignant. Okay. So sarcoma is a malignant tumor arising from mesenchymal connective tissues. So from fibrous tissue, you have fibrosarcoma. From fat, you have liposarcoma. From bone, you have osteosarcoma. For cartilage, from cartilage, you have chondrosarcoma. Smooth muscles will give rise to leiomyosarcoma. Skeletal muscles will give rise to rhabdomyosarcoma. So important exceptions to this OMA rule is melanoma is malignant, lymphoma is also malignant, seminoma is malignant, hepatoma is malignant, teratoma may be benign or malignant. So in general, though we have mentioned that benign tumors are designated with the prefix as OMA, then also there are some important exceptions and you should know this because they may ask a SBA on this particular theme. Okay. Then coming to the spatial tumor-like lesions, like papilloma. It is a benign epithelial tumor with finger-like projections. That is papilloma. Then polyp. It is a projection above the mucosal surface. So examples are colonic polyp, nasal polyp, etc. Then there are hamartomas. So hamartomas are the disorganized overgrowth of a mature tissues normally present at that particular site. This is not a true neoplasm. This is just the disorganized overgrowth of a mature tissues normally present at that particular site. Example is a pulmonary hamartoma. Characteristic of this is that it grows at the same rate as the surrounding tissue, and this is a developmental malformation. This is what you should remember as far as hamartomas are concerned. Then there are choristomas. These choristomas is nothing but the normal tissue in an abnormal location. For example, if the pancreatic tissue is present in the stomach wall, this is a choristoma. Then cytological features of the malignancy. Okay, there are various cytological features such as pleomorphism. That is the variation in the size, shape, nuclear appearance. Okay, so in the figure you can see that this normal cell is very well delineated. It has got a regular nucleus. It has got a adequate cytoplasm. Okay, normally the nucleus is relatively small and the cytoplasm is big. If this cell becomes malignant cells, in that particular case, you will have various features such as hyperchromatism. There will be increase in the nucleus to cytoplasmic ratio. Irregular nuclear and cytoplasmic outline will be there. Then there is a multinuclearity, multiple nuclei and presence of multiple nucleoli will also be there. So various features in pleomorphism, you will get cell size, cell shape, nuclear appearance variations you will see. Then you will have hyperchromatism. Okay, so this is a hyperchromatism, darkly staining nuclei due to the excess of the DNA. Then there is a coarse chromatin, irregularly clumped chromatin is there. Okay, so in normal cells you will find the large cytoplasm, single nucleus, single nucleolus, and there is a fine chromatin. While in cancer cell you will find the small cytoplasm, multiple nuclei, multiple and large nucleoli, and there is a coarse chromatin. Okay, so these features also you should remember because they may develop SBA on these particular features. Then there is an increased nucleocytoplasmic ratio. High NBC ratio is due to enlarged nuclei. Then abnormal mitotic figures, numerous mitosis, tripolar or quadripolar spindles you will be able to see. Then there is a prominent nucleoli, large irregular nucleoli will be present. Then differentiation in neoplasia. What is differentiation? The degree to which the tumor resembles the tissue of origin. Because sometimes what happens in malignant cells, the differentiation is very poor. It may not resemble the tissue from which it has began. Okay, so differentiation is the degree to which tumor resembles the tissue of origin. So accordingly the types are, it may be well differentiated, it may be moderately differentiated, it may be poorly differentiated. When we say about well differentiated, it means it closely resembles the original tissue, it has got a better prognosis. When we talk about moderately differentiated, it is an intermediate resemblance, and moderate prognosis, while poorly differentiated is a minimal resemblance and it has got a worse prognosis. Then there is a anaplasia. Okay, so there is a complete lack of differentiation. Features will be pleomorphism, giant cells, hyperchromatic nuclei, abnormal mitosis, loss of polarity. These are the features of an anaplastic cell. And this is the hallmark of aggressive malignancy. So once you see the anaplasia, that is the hallmark of aggressive malignancy. And the typical features will be pleomorphism, giant cells, hyperchromatic nuclei, abnormal mitosis, loss of polarity, etc. So when you compare the benign and malignant tumors, in short, we have already seen this. The growth is slow with benign. Capsule is present. They are well differentiated. There is no invasion, no metastasis. Recurrence is rare, and necrosis and bleeding is rare. While malignant tumor, they grow rapidly. No capsule. Differentiation is variable. It may be anaplastic also. There is an invasion. There is a metastasis. Recurrences are common. Necrosis and bleeding is very common with the malignant cells. Now coming to the etiology of neoplasia, there can be question on this particular topic, that is the etiology of the neoplasia. So please concentrate well. So tumor formation, basically it is a multifactorial and multi-step process. Okay, so it is not a single step process and it is not a one factor which is involved. It is a multifactorial, multi-step process. So there is a genetic basis for cancer. So first is there are proto-oncogenes. These are the normal genes which promote the growth. So when mutated, they will become the oncogenes. Example is that RAS gene. Okay. So on proto-oncogenes, these are the normal genes which will promote the normal growth. But if there is a mutation, they will behave like a oncogene. Then another gene such as tumor suppressor gene. Normally what do they do? Normally they inhibit the tumor formation, and if this is lost, then there will be development of the cancer. And examples are the retinoblastoma gene or TP53 mutation. Okay, so RB gene, TP53, these are the examples of the tumor suppressor gene. So these proto-oncogenes, and these tumor suppressor gene, these concepts are very, very important, including the examples you should remember, RB gene and TP53 genes. Okay, so there are proto-oncogene and there are tumor suppressor gene. Proto-oncogene will lead to the normal growth of the tissue. If there is any mutation such as point mutation, there may be hyperactive growth. Okay, while there are tumor suppression genes, normally they help in normal protein formation, so normal cell division is there. But if there is any defect, the defective proteins will be formed and there will be uncontrolled cell division. Okay, so remember proto-oncogenes and tumor suppressor genes. Proto-oncogenes normally will lead to the normal growth. However, if there is any mutation, it will lead to the oncogenicity. While tumor suppressor gene, if they are defective, again there will be oncogenesis. These tumor suppressor genes, they prevent the formation of the malignancy. Then there are apoptotic genes. They regulate the programmed cell death. Loss of apoptosis will lead to the tumor survival. Okay, normally the cell injury, when we will discuss, you will come to know there is a process called as apoptosis. There is a programmed cell death, but if there is a loss of this apoptosis, then the tumor will survive. The cell will not die, it will survive. Then there are DNA repair genes, repair damaged DNA. Okay, so defects will lead to the mutation accumulation. Then there are important oncogenes such as RAS oncogene. It is present in 15 to 20% of human cancers. Mutation causes persistent activation. Okay. Then there are tumor suppressor gene, which we have just seen. These are RB and TP53 we have seen as an example. So retinoblastoma gene, it controls the cell cycle progression. Mutation is associated with retinoblastoma and many other cancers. Okay. There are few oncogenic viruses such as HPV causing cervical carcinoma, EBV, that is Epstein-Barr virus associated with the Burkitt's lymphoma, nasopharyngeal carcinoma, HBV associated with the hepatocellular carcinoma, and HTLV1 is associated with the adult T-cell leukemia and the lymphoma. So please remember these oncogenic viruses also. Okay, especially HBV. They can ask anything because these are the general or the basic subjects. Then hereditary cancer syndromes are there. There may be Mendelian inheritance. Examples are the familial retinoblastoma, familial adenomatous polyposis, and neurofibromatosis. They have the Mendelian inheritance. These are the hereditary cancer syndromes. Then carcinogenic agents such as chemical carcinogens. You have alkylating agents. Examples are the cyclophosphamide, busulfan. They themselves can induce the cancer. So these are actually anti-cancer drugs also, but they themselves can induce the cancer. Then there are nitrosamines. They are associated with the gastric carcinoma. So naturally occurring carcinogens such as aflatoxin. This is found in the contaminated groundnuts associated with the hepatocellular carcinoma. So aflatoxin is associated with the hepatocellular carcinoma. Then there are miscellaneous carcinogens such as asbestosis associated with the bronchogenic carcinoma, mesothelioma. Arsenic is associated with the skin cancer. Radiation carcinogenesis. UV radiation can also cause the cancer, especially the skin cancers may be because of the ultraviolet radiation. Then ionizing radiation can cause leukemia, lymphoma, thyroid cancers, etc. Pre-malignant lesions. Okay, so liver cirrhosis is a pre-malignant lesion for hepatocellular carcinoma. Chronic skin ulcer may lead to the squamous cell carcinoma. Ulcerative colitis can lead to the colonic carcinoma. Leukoplakia also can lead to the squamous cell carcinoma, and gastric adenoma will lead to the gastric carcinoma. So these are the pre-malignant lesions. Then coming to the next concept, that is the dysplasia. Okay, so dysplasia is a disordered epithelial growth with cytological atypia. Okay, so it is a disordered epithelial growth with cytological atypia. It is a pre-malignant lesion. However, basement membrane remains intact. So this you should remember. Even if there is a dysplasia, it is a pre-malignant lesion and the basement membrane is intact. Then there are grades of dysplasia. It may be mild dysplasia when it is restricted to the lower one-third of the epithelium which is affected. Moderate dysplasia when more than one-third of the epithelium is affected, and severe dysplasia when the full thickness involvement is there. It is also called as carcinoma in situ. So what are the features of carcinoma in situ? Carcinoma in situ is a severe dysplasia involving the full epithelial thickness, but there is no invasion of the basement membrane. Okay, so this is what is very important about the carcinoma in situ. They can ask the SB on this particular feature also. Okay, then invasive carcinoma. It occurs when tumor breaches the basement membrane. So when we label this as invasion, when the basement membrane is breached, we call it as a invasion. Okay, coming to the invasion of the cancer. What is invasion? It is the local spread into the adjacent tissues, and there are steps of the invasion. This also you should remember how this invasion happens and what are the factors which are responsible. So there are steps. First step is a detachment, that is the loss of E-cadherin mediated adhesion. So these cells which are adhered to each other or to the basement membrane, normally there is a loss of E-cadherin mediated adhesion, that is called as detachment. So the first step is a detachment. Okay, so invasion will begin with the detachment first. Second is the attachment to the extracellular matrix. Now these cells, tumor cell will bind to the laminin and fibronectin via specific receptors. Okay, so from the basement membrane, they will lose and they will attach to the extracellular matrix with the help of laminin and fibronectin via specific receptors. Then there is a degradation of the extracellular matrix. This tumor cell will secrete proteases and type 4 type of collagenases, leading to the basement membrane destruction. Okay, so then there is a destruction of the basement membrane. So you make a note that these protease inhibitors may have the therapeutic role, because these proteases are important for they are secreted by the tumor cells, and what they do, they damage or destroy the basement membrane. So when you give the protease inhibitors, they will act on this particular stage or the phase of this oncogenesis. Then there is a migration. So tumor cells will migrate under the influence of cytokines, growth factors, and the chemotactic factors. Okay. So how does the metastasis happen? Okay. What is metastasis? Metastasis is the secondary tumor deposit discontinuous from the primary tumor. So it is a secondary tumor deposit discontinuous from the primary tumor. And what are the roots of the metastasis? It may be lymphatic spread, which is common with the carcinoma. This also you should remember. Lymphatic for carcinoma, it is the lymphatic spread. Hematogenous spread is common in sarcoma. Common sites are the liver, lung, and bone. Then you have a transcelomic spread. It occurs across the body cavities. Examples are the gastric carcinoma, leading to the reaching the ovaries through the body cavities, leading to the formation of Krukenberg's tumor. This is the classical example of transcelomic spread. This also you should remember from examination point of view. Then implantation, inoculation, that will lead to the direct seedling, then spread through the natural passages. Along the ducts or through the lumen, there can be spread of the malignancy. So important steps in metastasis. These steps also you should know. We have seen the steps of invasion. Now we are talking about the steps in metastasis. The most important step here is a angiogenesis. This is very important because most important step is angiogenesis. Tumor develops new blood supply, and the key factors are the vascular endothelial growth factor and FGF. Okay, so VEGF and the FGF are the very important growth factors for the process of angiogenesis. The sequence of metastasis is first angiogenesis, then there is a local invasion, then there is intravasation, then there is a circulation, then there is a arrest in the distant organ, then there is a extravasation, then there is a micrometastasis formation, and then there is a macrometastasis formation. So it begins with the angiogenesis, that is with the development of the new blood supply, and the factors responsible are VEGF and FGF. You should remember this, and these are the 8 steps for the metastasis. Okay, so coming to the staging of the cancer. So clinically, you have stage 1, which is a localized tumor. Then stage 2, it is a locally invasive tumor. Stage 3, it has got a regional spread. Stage 4, it has got a distance metastasis. Okay, these stages also in general you should remember. Stage 1, localized. Stage 2 is a local invasion. Stage 3 is a regional spread, and stage 4 is a distance met. Then there is a TNM staging. Okay, so TNM staging, where T stands for tumor size, N stands for nodal involvement, M stands for metastasis. So example is a T1 to T3, N0, N1, M0, M1. Okay, so next is a grading. Now there is a difference between the staging and the grading. Staging is your uh, is the spread of the tumor, while grading is the microscopic appearance and the differentiation. So please, these are two different concepts, staging and the grading. Okay, staging is the anatomical spread, while grading is pathological differentiation. Okay, so these concepts you should remember. So based on the microscopic appearance and differentiation, it may be grade 1, that is well differentiated, grade 2, that is moderately differentiated, grade 3, that is poorly differentiated, and grade 4 is anaplastic. Okay, then tumor transformation. Okay, so normal cell is transformed into the neoplastic cell. So it may be because of the persistent injury or the inflammation, and that increases the chances of the mutation. And once there are mutation, then there is a formation of the cancer cell. Okay, so precancerous conditions, this we have seen. Cirrhosis will lead to the hepatocellular carcinoma, ulcerative colitis will lead to the colonic carcinoma, atrophic gastritis will lead to the gastric carcinoma, and actinic keratosis, squamous cell carcinoma, it will form, and oral leukoplakia may form the squamous cell carcinoma. Then there is a tumor progression. So gradual acquisition of the malignant characteristics. So from hyperplasia, it will develop into dysplasia to carcinoma in situ, and finally it will develop into the invasive cancer. Okay. Then there is a next concept of tumor heterogeneity. This also you should remember. What is tumor heterogeneity? Okay. So different tumor cell clones acquire different properties. So within the same tumor, the different cell clone will have the different properties. From the same tumor, different cell will have the different properties. For example, there will be properties such as drug resistance, increase in invasiveness, metastatic potential, immune invasion, etc. So clinical features of the cancer. So it can cause local effects. It may lead to the obstruction or pressure, like a pancreatic carcinoma causing obstetric jaundice. There may be ulceration and bleeding seen in gastric carcinoma or colonic carcinoma. Then infection, it may be because of the obstruction. Okay, so that will lead to the pneumonia, urinary tract infection, etc. Sometimes this tumor can rupture, as you see in ovarian carcinoma, colonic carcinoma, etc. Then there may be systemic effects such as fatigue, and this is due to the metabolic disturbances. There may be anemia, which may be because of the chronic bleeding, bone marrow involvement, and may be associated malnutrition. Then there is a specific associated with the cancer is a cancer cachexia. Now this cancer cachexia, you should remember that there will be weight loss, muscle wasting, weakness, anorexia. And why this cancer cachexia develops? It develops because of TNF alpha and cytokines. So it is not only because of the intake of the nutrition, but it is mediated by these chemical mediators such as TNF alpha and cytokines, and hence it may not get recovered only with the nutrition. That also very important thing which you should remember. Then there are paraneoplastic syndromes. These are also important from your SBA point of view. These are the symptoms caused by the tumor products rather than the tumor mass itself. So these are the products of the tumor. They will lead to the symptoms rather than the tumor itself. Okay. So these tumor markers also you should remember. Cushing syndrome because of the ACTH produced by the small cell lung carcinoma. Then SIADH, syndrome of appropriate ADH secretion. It is associated with the lung carcinoma. Then hypercalcemia associated with the squamous cell carcinoma, and hypoglycemia generally associated with the fibrosarcoma. Coming to the diagnosis of neoplasia, the clinical diagnosis, the symptoms will be weight loss, mass, bleeding, anemia, etc. And imaging such as X-ray, ultrasound, CT scan, MRI will be required. The tumor markers also you should remember from examination point of view. PSA is very specific for prostate carcinoma, that is prostate specific antigen. Then alpha fetoprotein for hepatocellular carcinoma, and alkaline phosphatase for the bone tumors. Cytology, example is the FNAC, pleural fluid cytology, ascitic fluid cytology. They will help us in diagnosis of the cancer. Then histopathology, that is the gold standard for the diagnosis. And you take two different types of biopsies are there. One is an excision biopsy where you take out the complete mass of that particular tissue or the cancer. Other is the incision biopsy where you take the normal part plus the affected part. Okay. The special techniques such as immunohistochemistry is there. There are special stains which can be used for the histopathology. Then molecular techniques such as PCR, FISH, RFLP. So PCR is polymerase chain reaction, fluorescence in situ hybridization, that is FISH, and restriction fragment length polymorphism, that is RFLP. These are the molecular techniques which can be used for genetic diagnosis, tumor characterization, and the prognosis. Okay. Now metastasis. So what is metastasis? Metastasis is the spread of malignant tumor cells from the primary site to the distant site without direct continuity with the original tumor. Okay. So in metastasis what happens? There is a spread of malignant tumor cells from the primary site to the distant site without direct continuity with the original tumor. And metastasis is the most important feature distinguishing benign from the malignant tumors. There are steps of tumor invasion and metastasis. The first is a loss of cell-to-cell adhesion. So malignant cells lose adhesion molecules, especially E-cadherin. Cells detach from the neighboring tumor cells and loss of polarity and the cohesion occurs. So there is a decrease E-cadherin and there is an increase invasiveness. Second step is attachment to the extracellular matrix. So tumor cells attach to the laminin and fibronectin collagen. So tumor cell express receptors for extracellular matrix proteins. Third is the degradation of the extracellular matrix. So tumor cells secrete proteolytic enzymes such as type 4 collagenase, then matrix metalloproteinases, that is MMPs, and proteases. So these enzymes will destroy the basement membrane, degrade the collagen, and facilitate the invasion. So clinically, these protease inhibitors may help to prevent the tumor spread. That also we have discussed. Then next step happens migration of the tumor cells. So these tumor cells will migrate under the influence of cytokines, chemotactic factors, growth factors, etc. Okay. So there are ECM degradation products also. Next important step is angiogenesis. So formation of the new blood vessels from the pre-existing vessels. Importance in the cancer is that tumor requires the blood supply for oxygen, nutrients, metastasis. Without angiogenesis, tumor cannot grow beyond 1 to 2 millimeters. So this is very important, angiogenesis, for the tumor to grow. Otherwise, tumor will not grow more than 1 to 2 millimeter without angiogenesis. And the factors which are responsible are the VEGF, that is vascular endothelial growth factor, and FGF, that is fibroblast growth factor. This also we have seen. Now just see that this is the primary tumor. From this primary tumor, they develop the angiogenesis. So angiogenesis is the new blood vessel formation. So once this angiogenesis is there, then what happens? From primary tumor you are developing this angiogenesis, then there is a invasion. Okay, so there is a intravasation. Okay, from then there is a migration. From migration then there is a extravasation. From extravasation these cells will go out and will form micrometes. Okay, and from micrometes further there will be development of the macrometes. So these are the different stages of distant spread. Okay, so steps of the metastatic spread are the angiogenesis in the primary tumor, then there is a local invasion, then there is intravasation into the blood or the lymphatics, then there is a survival in the circulation, then there is a arrest in the distant microvasculature, then there is a extravasation into the tissues, formation of the micrometes, and the growth into the macrometes. Okay, so this primary tumor, then there is angiogenesis. From angiogenesis there is a local invasion, there is a intravasation. These cells will go into the blood vessel. Then there is a migration. From migration, then there is a extravasation. From then this extravasation, there is a formation of micrometes, and then there is a macrometes. Okay, so routes of the spread for the malignant tumors: lymphatic spread we have seen most commonly for the carcinoma. Breast carcinoma will go to the axillary group of lymph nodes. Then what is sentinel lymph node? It is the first draining lymph node from the tumor site. So first draining lymph node is the sentinel lymph node. Hematogenous spread is seen with the sarcomas. Common sites are the liver, lung, bone, brain, etc. Colon carcinoma will metastasize to the liver, while osteosarcoma will metastasize to the lung. Then there is a transcelomic spread across the body cavities. So ovarian carcinoma will spread via peritoneum. Then gastric carcinoma will lead to the ovary, migrate to the ovary through the peritoneum, and it will form the Krukenberg's tumor. This also we have discussed. So metastatic signet ring adenocarcinoma of the ovary is usually from the stomach. This is also a SBA which has been asked. Okay. Then there is a direct local invasion. Tumor infiltrates adjacent structures directly, such as carcinoma of cervix involving the bladder, rectum, etc. Then there is a spread through the natural passages, such as bronchi, fallopian tubes, urinary tract, etc. Coming to the staging of the tumor. Staging is the clinical assessment of the tumor size, local invasion, nodal involvement, distant mates. So staging is important for prognosis, treatment planning, and survival prediction. Okay. So clinically, this we have seen stage 1, 2, 3, 4. This we have discussed. Then TNM stages also we have discussed. Grading also we have discussed, that is the microscopic assessment of the differentiation and the anaplasia. Grading depends on the cytology, histology, degree of differentiation. Grade 1, 2, 3, 4 also we have discussed. Okay. And the behavior depends upon the differentiation. If it is a well differentiated, it is a low grade behavior. Moderately differentiated, it is intermediate. Poorly differentiated is high grade, and anaplastic is a very aggressive. Okay. So there is a difference between the differentiation and the anaplasia. Differentiation is the degree to which the tumor will resemble the parent tissue, while anaplasia is the lack of differentiation. So these two things you should remember, because these concepts they can check in the SBA. Then what are the features of anaplasia? Pleomorphism, hyperchromatic nuclei, high N by C ratio, abnormal mitosis, giant cells, loss of polarity. This also we have. So take home message is that metastasis is the hallmark of malignancy. Carcinomas spread mainly by lymphatics. Sarcomas spread mainly by the hematogenous route. Angiogenesis is essential for tumor growth. Carcinoma in situ, there is no basement membrane invasion. Cachexia is mediated by the TNF alpha. Okay. Histopathology remains gold standard for the diagnosis in cancer. Tumor grade is not same as tumor staging. Tumor staging is the clinical involvement of the by the cancer, while tumor grade is the pathological nature, okay, the differentiation and etc. Then stage determines the prognosis better than the grade in many cancers. So staging is different and the grading is different, okay. So this is what is about the neoplasia and the metastasis. Doctor, we have few questions. Can you please attempt these questions, one of you?
Yes, sir. A 6-year-old child presents with leukocoria and is diagnosed with retinoblastoma. Leukocoria and retinoblastoma. Which molecular mechanism best explains tumor development in this condition? Activation of oncogen, single hit mutation in a proto-oncogen, two hit inactivation of tumor suppressor gene, epigenetic activation of growth factors, increased telomerase activity. Sir, option C, two hit inactivation of a tumor suppressor gene.
So tumor suppressor gene here, because RB we have seen there is a in RB, that is retinoblastoma, tumor suppressor gene function is getting hampered. So retinoblastoma involves mutation of RB1 gene, a tumor suppressor gene. According to Nelson's hypothesis, both alleles must be inactivated. So it is a two hit for the tumor formation. Okay, next.
Yes. A tumor shows impaired apoptosis and accumulation of DNA damage. Impaired apoptosis and accumulation of DNA damage, mutation of which gene is most likely? Impaired apoptosis and accumulation of DNA damage, mutation of which gene is most likely? KRAS, MYC, TP53 gene, BCL2, HER2, sir. Sir, impaired apoptosis, sir, TP53 gene.
Yeah, because it is concerned with the uh, repair mechanism. Okay. So role of
Yes.
P53 regulates DNA repair, apoptosis, cell cycle arrest, etc. That is by the P53. Loss leads to the genomic instability and survival of the damaged cells. Okay. So these concepts are very important. They are asking these basic things. Next.
Which of the following represents activation of an oncogene, deletion of both RBLEs, point mutation of RAS gene, loss of P53 function, hypermethylation of BRCA1 promoter, loss of APC gene?
That is the point mutation in RAS gene. Yes, RAS gene also we have seen the first. That is the which of the following represents the activation of an oncogene. So here it is an activation of the oncogene. There what we have seen, loss of the function. Okay,
Uh-huh.
repair mechanism. Here it is
Mhm.
activation is in the RAS gene.
The retinoblastoma protein primarily regulates which phase transition? G0 to G1, G1 to S, S to G2, G2 to M, M to G1. Maybe option C, sir, S to G2.
It is answer is cell cycle control. It is option B. So retinoblastoma, this protein inhibits E to F transcription factors, preventing progression from G1 to S phase. Okay, G1 to S
Yes.
phase. Remember
G.
these few things because it's a very vast. So whatever you can grasp, try to grasp. Next.
Yes. Which of the following is not a hallmark of cancer? Sustained angiogenesis evading apoptosis is not a hallmark of cancer.
Mm.
Sustained angiogenesis evading apoptosis, genomic stability, self-sufficiency in growth signals, tissue invasion and metastasis. Not a hallmark is genome stability. Option C.
Yes, because unstable genome will lead to the oncogenesis. So cancer cells show genomic instability and not stability. Next.
Which step is essential for metastasis? Increase apoptosis, loss of adhesion molecules, decrease angiogenesis, reduce motility, increase differentiation. So loss of adhesion molecules, option
Yes,
B.
that is the first step which happens. Loss of adhesion. Uh, so loss of adhesion molecules, that is the E-cadherin, allows tumor cells to detach and then invade. Okay.
Hypercalcemia in malignancy is most commonly due to secretion of calcitonin, vitamin D, parathyroid hormone related peptide, ACTH or growth hormone. So option C, PTH related
PTHRP.
peptide.
Okay. Parathyroid hormone related peptide. Okay. It is a paraneoplastic syndrome. Many tumors secrete PTHRP, mimicking PTH and causing hypercalcemia. Next.
Which feature is most indicative of malignancy? Encapsulation, slow growth, Poor differentiation, lack of mitosis, localized growth, which is most indicative of malignancy. So poor differentiation.
Yes, poor differentiation. Anaplasia is a hallmark for
Yes.
malignancy. Next.
Which phase involves irreversible genetic damage? Which phase involves irreversible genetic damage? Damage, initiation, promotion, aggression, progression, metastasis, angiogenesis. Irreversible genetic damage. Which phase involves irreversible genetic damage? Metastasis, option D.
That is
There is
definitely there
metastasis.
is a damage, but I think it should be angiogenesis. A.
Oh,
Initiation.
yeah.
Irreversible genetic chemical carcinogenesis. Initiation causes permanent DNA mutations. Promotion is reversible. Okay. So initiation causes permanent DNA mutation. Promotion is reversible. Next.
Which virus is strongly associated with cervical carcinoma? Sir, HPV virus, option C.
Yes, yes. Viral oncogenesis. High risk HPV, that is HPV 1618, produce E6 and E7 proteins that inactivate P53 and RB. Okay. So these are the
Yes.
products which are formed E6, E7 proteins. Next.
Which describes tumor staging? Sir, option E, histological pattern.
Is it? I told
Yes,
you
sir.
staging and grading.
At
What?
staging, okay, I reversed it. Okay, sorry. Degree of differentiation, mitotic activity, extent of option C, extent of tumor spread.
Yeah, that
Yes,
is you think of anatomical and pathological. Okay.
surgical, yes.
Huh?
Yes.
So tumor grading versus staging. Staging refers to the anatomical spread, that is TNM. Okay. Then while grading refers to the differentiation.
Differentiation.
Next.
Which factor is most important? Tumor angiogenesis. PDGF, TGF beta, vascular endothelial growth factor. So option C, vascular endothelial growth factor.
Yeah, VEGF, angiogenesis factor. VEGF, vascular endothelial growth factor, is the key mediator promoting new blood vessel formation in tumors. Okay. So that
Yes,
finishes
sir.
the topic of neoplasia and metastasis. We stop here. Thank you.